Please help welcome our next speakers.
Well, I've got 3 kids at home, and they made me promise to lead off my talk with a dad joke, so I'm just going to fall in line with mine. And also, because I'm a psychiatrist, I also feel sort of doubly bound to telling a joke right now. This one's about a moth who showed up at a podiatrist's office. And the podiatrist sat down and said, "Well, Mr. Moth, what seems to be the problem?" And the moth said, "Well, it's actually a lot of things. See my antenna right here? It's kind of broken, it's sideways, it's hanging off to the side. See my little foot down here? It just hurts and I can't seem to get the hurt to go away. And I have this feeling in the pit of my stomach and I just feel nauseous and I can't eat. And sometimes I just wake up and I look in the mirror in the morning and I wonder, why am I even here?" And the podiatrist says, I'm a foot doctor. What brought you to me exactly?" And the moth said, "Well, the light was on." And I actually think that joke is pertinent for us here as people who are healers, who are emergency responders, who work for nonprofits. We're drawn to this work sometimes just because that's who we are. And I find myself often when someone asks me sort of why I do what I do, and the real answer is it's just because I just was drawn to it. It turned out to be who I was. There's not a logical reason. So when I saw that our talk was sandwiched between a fire and a building collapse, I got a little bit nervous because it seemed like those were 2 intense things to have to sort of find space in between. But, in a way, it actually makes perfect sense because as people who deal in emergency, 99.9% of the time, there's not an emergency happening. And so what we're talking about is what happens in between the emergencies and how to keep morale up and how to stop ourselves from becoming demoralized from a system that's broken. And I've heard moral injury described as death by 1,000 cuts. And I think that's sort of what happens to a lot of us. Has anyone in this room ever experienced burnout, whether a major or minor form of it in their work? And so moral injury and burnout are closely related concepts, as we will be getting into. Before I go further, I just want to get to know the audience a little bit. I'm a doctor and I'm used to speaking to doctors and nurses, but not rooms full of all sorts of other kinds of people. So are there actually any other physicians in the room? Are there any nurses in the room? Ooh, lots of nurses. Emergency medical personnel? Social workers? Nonprofit administrators? Okay. And any administrators for any health systems or hospital systems?
Did we miss anybody?
Firefighters.
Firefighters. Ah.
Public health. All right. Are there any police, law enforcement, Red Cross? I could tell by your shirt. Very iconic. All right, well, without further ado, I'm going to turn things over to Maureen Sweeney, my partner in crime today. And she's going to tell you guys a little bit about what we do in our work, and then...
Oh, we can't get too close to each other.
Start describing the concept of moral injury.
Thank you, Dr. Goldenberg. As Dr. Goldenberg said, my name's Maureen Sweeney. My background is in psychiatric nursing. I've been working in community mental health for the last 10 years, and right now I'm the Director of Clinical Strategy at Frontline Service. Who's familiar with Frontline Service in this room? All right, we'll get to a slide where we just kind of go over our services too. So today we're going to talk about, as Dr. Goldenberg said, moral injury and the role in burnout. We're going to identify how the COVID-19 pandemic has disrupted our systems, led to an increase in moral injury. identify ongoing costs of systematic moral injury in the medical field, and then understand the concept of moral resiliency and cultivating it, not just as individuals, but also as leaders and systems. So Frontline Service, right, our mission is Frontline Service is a private nonprofit organization that reaches out to adults and children in Northeast Ohio to end homelessness, prevent suicide, resolve behavioral health crisis, and overcome trauma. So we're a community mental health center. Dr. Goldenberg and I both work in the clinic, and Dr. Goldenberg runs our crisis stabilization unit right now as well. The people we mostly serve are the seriously mentally ill who are also struggling with homelessness, and then also those dealing with crisis. All right, why do we need a new lens, right? We have the dialogue of burnout. We already know kind of how to describe it. But when people are using the term burnout, what do we think of, right? We think of cynicism, somebody's really difficult to work with, their productivity is decreasing, they're not really present at work. It's a lot of looking at individuals and assessing like where they're at and what have they done that have gotten them there, meaning, did they need a vacation? Did they not do enough yoga? All of those things that we know, it kind of shifts it from the system being an issue to the person being an issue. You know, what can you do more to help your resiliency? So that's kind of a struggle with burnout and why maybe moral injury might be a better way to describe it. Have people heard the term moral injury before? Yeah, some of you? Okay. So we're going to get into that. So moral distress or moral injury, first off, there's a bunch of different definitions out there, and depending on if you're in the nursing field or if you're looking at veterans, it might be slightly different, but it's all kind of the same concept. So moral distress or injury arises when a healthcare worker faces moral adversity, must make a moral judgment about the most ethically justified response, and act on it in a situation where the consequences of action or inaction impair their moral integrity. What does that mean, though, right? That means that often we work in systems, and the systems that we work in have us facing situations that we don't get to do the care that we want to do in the way that we want to do it, and we have to make decisions, and sometimes those decisions go against our morals and our values. And the distress that comes along with that is moral injury. So before I get into this next part, I just want you guys to take a couple minutes at your table and just talk through what are some moral injuries that you have faced in your careers, not just with the pandemic, it can be pre-pandemic as well, but just take a couple of minutes and kind of talk through what does moral injury look like for you personally. All right, we're going to come back together now. Does anybody have any circumstances they want to share? I've got one that I can share. Yeah, go ahead. Say it one more time. Yes, right? So the insurance barriers we all face, that's a really good one. Anybody else? Okay. Sometimes our policies, right? I think back to when I was inpatient. I used to be a labor and delivery nurse. I was just telling this table over here. So I can remember coming out of nursing school, being a fresh new grad and so excited to practice. And one of the policies we had at the time was that you would suction the baby, usually about 3 times after delivery, and especially if there was a C-section. But I had just come out of nursing school, evidence-based practice, and I was so bright-eyed and bushy-tailed, and I said, well, that's not actually evidence-based practice, and it can lead to more breathing issues. And so, of course, my lovely, not burnt-out coworkers reported me to management, and I had to face either being written up or following a policy that I knew wasn't evidence-based and was actually causing more harm than good. So I said, go ahead and write me up. They didn't, but they could have. And so that distress that you feel, right, when you're having to face that, that's a moral injury. So I love how they say it here, right, the inability to provide quality care in the context of a broken system. Journalist Diana Silver said it in a really nice way. The reason I love nursing is because I got into nursing just really practically, right? There's employment in nursing, there's an okay salary, so when I was going into college, I'm like, all right, that's where I want to go. But when I got into nursing, I fell in love with it, both because there's a lot of heart there, but then there's also a lot of common sense. So like that combination it just sent me over the moon, and I fell in love with the profession. So there's a lot of heart in healthcare in general, but I love how Diane Silver describes moral injury. She says, it's a deep soul wound that pierces a person's identity, sense of morality, and relationship to society. That just really kind of hits home to what we're talking about here. So there's a cost, right? When we're coming up against this moral distress, these moral injuries, small, right? Death by 1,000 cuts, or sometimes huge, like some of the stuff we dealt with in the pandemic, or some of the stuff that you guys were facing when you were talking about that fire. And we see the toll on mental illness, and sometimes it really overlaps with PTSD, and of course some people in healthcare can have both PTSD from moral injury. But when you're just talking about moral injury and the overlap, you can see a lot of anger, depression, anxiety. People start to have trouble sleeping, maybe an increase in substance use. You start to see people not engaging in activities that they used to enjoy. There's a lack of trust. You see a lot of shame and guilt, just because they're faced with impossible situations all the time. They have to make the best decisions they can in those situations. All right, so COVID-19 and moral injury. So pre-pandemic, I think we can all agree, right, that our system had cracks. It was pretty broken. We knew that even back in 2019. Whether it was institutionalized racism, whether we're talking about sexism, insurance issues, I had that up there too. So we knew there were cracks in the system. But I think society was only peripherally aware of it, right? So people could argue like, oh, this is a bigger problem or that's a bigger problem, and they were just kind of cracks that we all didn't agree on. The pandemic hit, right? There was an acute response. So 2020, acute response, there's kind of, at least in the beginning, a shared responsibility, right, across society. Even though there's a lot of rhetoric going on and, there was a lot of infighting with everything that was going on politically, but there was a larger sense of shared responsibility of what does this mean for us. And I think during that time, too, you saw an increase in coordination across sectors, right? So healthcare might have been working with food distribution, might have been we were all working kind of together, and it was a struggle. It was really hard, but I don't think any of us were prepared for what that long-term pandemic response was. So when the long-term, where we are now, where we continue to live, the new normal that we all deal with, the cracks that I talked about earlier became chasms, right? Chasms that whole populations started to slip into. There was no longer just visible to us in the healthcare system, but society as a whole kind of saw these chasms. And I think the hardest part, at least from my perspective, has been the understanding that society knows and that society isn't taking the responsibility to mitigate the risk, but they're more than comfortable with us taking on that risk in healthcare. And I think that understanding is where we start to see a lot of healthcare workers leave the field, because they're just not okay with that. If we have the risk, if we're bearing that brunt, what is society's role in mitigating? And when the answers were crickets, I think people were like, I can't do this anymore, and they started to leave, which, as we all know, has led to some crazy, crazy staffing crises. Who's dealing with staffing at work? Yeah, right? And good people left. These weren't people who weren't resourceful enough, didn't do enough yoga, right? These were good healthcare providers who just couldn't do it anymore. Oh, that leads into my next slide beautifully. So we can't MacGyver our way out of this one. That's from Talbot and Dean, right? Healthcare providers in general are really resourceful people. If there was a way to kind of usher ourselves through this, we would be finding that way. But the fact is that physicians are committing suicide at twice the rate of active military members. And I think they made such a good analogy that that's the canaries in the coal mine, right? That doesn't mean these workers are broken. That means that the system is broken, right? And we need to take a look at that. Like, that's a huge number. And that number is actually from 2018. I bet if you had numbers now, it's even more. So it's been pretty bleak, right? We're supposed to be like the comedy, the relief, the usai. So we wanted to talk about, right, the shared definitions and kind of come together around moral injury, but we also wanted to talk about what the answer is. Before I get into this next piece, I will say the first time I heard about moral injury was like the first time I heard about trauma-informed care. It was naming what I knew to be true intrinsically. And so that's why, to me, it resonates so well. So I love my little comic up there. Does anyone feel like we could be doing this better, right? And I don't mean we in this room. We are trying to do this better, but society as a whole, we need to be doing this better. So the answer is moral resilience. So when we talk about moral resilience, we talk about the capacity to sustain or restore one's integrity in response to moral adversity, right? So if you go back to the example I gave as a brand new, bushy-eyed nursing, entering the nursing field, I was able to navigate that situation by choosing not to move away from my integrity. And I was able to do that because I had really good mentors. I had really good nurses around me who were like, yeah, they write you up, so what? And to help me navigate that moral distress that I was feeling at the situation. So that's moral resiliency on an individual level. I love, you can't see this graphic, it's kind of messy, but I wanted to put it in because I love how it navigates, right, from moral distress to kind of moral resiliency, and they talk about what does that look like. It talks about speaking out. It talks about honoring resilience and the work that we do and never doubt the progress. That's hugely important, right? Perspective. When I think about the pandemic and Frontline, I know our director of housing is here somewhere. Oh, she's in the back of the room. Hey, Jen. We had talked about triage in the presentation before us. And what we know, too, is that with the pandemic, there was a shift to we're going to help the most amount of people survive. But for us who are dealing with people in community mental health who have severe mental illness and homelessness, who die on average about 25 years earlier than the general population, guess who is the first to kind of fall off of that equation? So when society shifted to we have to help the most people survive, our little pocket that we're responsible for fell off. And so what we saw is people who should have been in inpatient, and there was just no room for them in inpatient. So now they're living in permanent supportive housing. We've got nurses and we've got social workers who are doing their best to kind of help in those situations when the person really needs a higher level of care. There's a huge amount of moral injury that was occurring, but how we kind of moved through that into moral resilience was working together, right? If there were staffing issues in social work, what can nurses do to help? If the social workers had time, how can they transport to the clinic to get people treatment? So sharing that responsibility so nobody felt like they were alone. And then also, I think another piece of it was how can we build partnerships with other people, those relationships that you guys talked about earlier. It's so important because then when we do really run up against systems barriers, real barriers, right? It's not like inpatient didn't want to treat our people. They didn't have room to treat our clients. Who can we reach out to in primary care? Who can I tap? Who's going to be there because we've been there for them? How can we build those relationships in the in-between moments? I am going to hand this over to Dr. Goldenberg after I turn.
When Maureen Sweeney talks about physicians being the canaries in the coal mine for this problem, that hits me hard as a physician. It makes me worried about myself and my friends and the people I trained with. But really, I think I don't want you guys to feel like we're just talking about doctors or nurses. I think everyone in this room falls into that category of being especially prone to suffering moral injury. In the case of physicians, if you think about where this might come from, you have people that sacrifice years of their life. Like they sacrifice their entire 20s to go to school and then med school and then residency. They sacrifice all sorts of income that they could have made during that time because they just want to help people. And then you put them in this system where they have to sit and stare at like an electronic medical record all day that's like a glorified cash register, right? And they're lucky if they're able to look up and see their patient. And you put them in this system where they know what the right thing to do is, but the insurance company makes them fight for a week in order to do that thing. It's not hard to see how that could happen for physicians. And I think that the main take-home point, if there's any take-home point from this whole talk, it's that the answer can't just be to tell people that they need to be better at taking care of themselves, that they need to do more self-care, they need to do more reflection, because the real answer is in fixing a system, so the system no longer does this to us. And so this graphic here just introduces the example of a system that is basically a system that actually heals itself, that knows itself. They talk about the cycle of quality improvement where you plan, do, study, act, the PDSA model. And for people like us that just want to act because we know what the right thing is, sometimes over time that can create systems that aren't really working well or that are even toxic. And so taking the time and really having like robust quality improvement, robust cycles of figuring out what the problem is, trying a solution, measuring and studying what happened, those are really important. So we can't shy away from those kinds of things in our organization. It needs to be an active part of what we're doing. And this is one thing that we see a lot with what we work, that if you see people doing a lot of workarounds, workarounds are great until they're not. And workarounds can sometimes be a red flag that there's some missing or broken or just untended to part of the system that you're working in. I was thinking about this earlier this week because there's a partner hospital that we have that we share a lot of our clientele with. And the only way we could figure out what was going on with one of our clients who was in that hospital was for me to personally call the physician from that hospital who I just so happened to know from outside of work. That was the only way we could get information about what was happening with our patient that was there. And in the moment, that got us the information we needed, and our social workers jumped into action and could take it from there. But without me doing that workaround, they couldn't figure out what floor the person was even on or what their condition was. And so that's a problem. And, I think there's a bigger answer there at a systems level where we need to work on our relationships, not just within our own workplaces, but with our partners, with the people that we do transitions of care to and from, with the people that we share essentially the same economic and societal costs for all these decisions with.
I wanted to just interrupt real quick. I think it's really important to identify too that we as leaders need to be we need to be really connected to the direct service staff and what they're doing, because if we're not, we don't see where the workarounds are. Where are they working around the system that we've built for them? Because that's important for us to decide, does the system need to be revamped? Both of us, even though we're in leadership, keep one foot in practice because it's really hard to build a system that you don't have to use. So I would just, if anybody is here who maybe doesn't connect much with their direct service workers, I would really recommend that you do so, just because they're working around the systems that we're building.
And everybody loves RBG. She said, fight for the things that you care about, but do it in a way that will lead others to join you. And that's the trick, isn't it? To be able to identify things that are wrong, but focus on working together to find the solutions, not focusing on whose fault it is or who did what wrong. And this kind of, I already mentioned this a little bit, but building strategic relationships. My God, how important. Hearing about the fire and all the different entities that had to work together to get those people somewhere safe was unbelievable. for us, we see a huge source of moral injury there might be a patient that we've been working for years or decades with to stabilize, and then they transfer to some other level of care, and the ball is dropped, and we see all sorts of work just disintegrate in front of our eyes. Or we see someone who is stabilized in like an inpatient hospital. They leave that hospital without the proper communication, without the proper linkages, without the proper, strategic conversations, and all the gains that were made fall apart. And, you see this once, you see this twice, it's okay, but when you see it dozens and hundreds of times, it takes a toll too. And so I feel like this has been touched on in just about every talk today, and probably will be touched on in the rest of the talks too, but just building relationships, building strategic alliances, not being afraid to sort of reach out to our colleagues that are doing the same work at different levels is just hugely important. It's also important to listen to each other. That's also something that I think has been already mentioned and deserves to be mentioned over and over again. If you ask for feedback, if you ask your direct service staff to tell you what's wrong with the system, you have to really sit back and listen. You have to avoid the pitfall of cutting them off and jumping in and assuming that you know where they're going when they start talking, because that way you won't really get the good stuff.
One thing I wanted to mention too on that, can you go back to the last slide? Yeah. When we talk about measuring success, what does that look like, right? Because we had talked about, right, inpatient's different than outpatient. EMS has different goals than primary care. Everybody's got kind of their own lens that they're looking at this stuff through. So what are our metrics as a group? What are our metrics as a group? What does success look like for us? And that's where I think we really have to start looking at measuring success through population health, working with lawmakers and insurance providers to incentivize the right actions, right? We have to use our voices, our collective voices, to kind of speak truth to power. ID, right, when insurers are incentivizing poor care or cherry picking, I will insert my dad joke into here. 3 nurses go to heaven, and St. Peter's at the gate. The first nurse is a pediatric nurse, and he said, "Oh, you've done noble work. You can go right in." The second nurse worked on a burn unit and just devoted her whole life to her nursing practice, and he said, "Yes, of course, go right in." And the third nurse was an HMO nurse, and St. Peter said, "All right, you can go in." And she goes, "Phew, I thought you were going to say I couldn't go in." And he goes, "Oh, you can go in, but you can only stay for 3 days." So we really have to be talking. I mean, these things, they feel immovable to us, right, as leaders in healthcare. Like, well, it's insurance, it's Medicaid, it's federal government. Things aren't immovable, but we really have to be strategic about, okay, where is it that we want to make change, and what does change look like, and how do we make that change, and also look at unintended consequences. As somebody who has worked at least in Ohio, to adjust laws, sometimes there's unintended consequences, so it's important to think these things through, but I just wanted to add that. Go ahead.
Yeah, and I think in addition to that, some of the people that we might sort of like easily demonize, they might just be people who are just as morally injured as we are, looking for the right relationships or linkages or ways to change the system too. Maybe I'm an optimist. So system resilience, what does that look like? It's always a good practice to have a chief wellness officer. I think that projects to the entire organization that it's a value and a priority, and it's also someone who can actually dedicate all their time to this. I think it's a mistake to think that someone could just sort of add on dealing with burnout and moral injury is like, a couple hours a week kind of job in a big health system. It's not going to happen. It needs to be really a full-time job. we need to create a culture of ethical practice. And that could be having ethics rounds in your institution. It could be having like an outside ethics consultant that could be consulted for things when you're not sure what the right answer is. It needs to be ready access to mental health for employees. I'm not going to make you raise your hand, but if you're feeling, really strong hopelessness and moral injury or burnout, is there someone that you have access to that you can talk to?
For all those in Cuyahoga County, we did put mobile crisis pamphlets on there. Mobile crisis, like I said, is run by Frontline, but it's the county crisis hotline. So if you or any of your staff need link to care, it's free. We treat people with Medicaid, we treat people with no insurance, we treat people with private insurance while we link you to other resources. So I just wanted to make sure you guys knew that that's what those were and that's what we do.
And also, remember that moral injury doesn't have to be this nebulous concept that's hard to sort of measure. Someone came up with a way to measure someone's level of moral injury. It's called the Moral Resilience Scale, developed by Cinda Rushton, who we touched on a little bit and we'll go into a little more later.
She's a nurse. Just shout out
Yeah,
to
and
nursing.
we've actually begun to use that with our staff to assess like where they're at, between just moral distress and complete burnout. Creating an ethical culture. Be great to have some training in ethics, some training in reporting, so people know what to do in these really hard situations. It is also wonderful to have shared knowledge rather than sort of like knowledge that's protected and held at the top. Knowledge about this kind of thing needs to be disseminated widely. It needs to be included in all of our trainings at all of the different levels we work at.
Meredith Fratantonio, who's from Frontline, was sharing with me a little bit about this group of people, and I think it's really important to identify, right? So many people in this room are kind of the go-getters, the people that will bend over backwards, the people that, as the system's falling apart, have caught a lot of people, the ones that they were able to catch with this pandemic, and I just think it's so important to look at how can we shift that from being the duty of an individual to being a duty of the system. Because if people burn out, if people leave, they leave with all of that energy. They leave with all of that knowledge that they've collected over time. So I'm a huge proponent of systems, and if I'm doing my job right, I can step away and my system runs well. If I'm doing my job wrong, when I step away, things will fall apart. So I think it's really important to look at that.
Now, if you look at this next diagram, it sort of shows how the system creates these conditions for people. So you have just the practice of healthcare, which in itself every day creates moral dilemmas, which create moral distress. And then you have the working conditions in the different settings and hospital systems and communities that we have. And so if you have a healthcare workforce that is experiencing moral distress, there's a lot of systemic forces and environmental forces working on them to turn that moral distress into moral injury and in turn flip them into a full burnout mode. This is meant to illustrate that there's steps along the way where interventions can happen. When people are experiencing moral dilemmas at work, you can have reflection rounds, you can have ethics consultations. When people are actually in moral distress, we need to figure out how to improve staffing, decrease workload, easy stuff, right? Have real discussions happening in real time in the workplace, have mental health support for people. And then when people are in the full-on moral injury and burnout mode, they need their mental health support, wellness programs, wellness consults, on-demand psychological support. It's also important.
I would underestimate, too, just the power of naming it, right? Especially the stuff around equity, I think about how hard it has been to watch the inequity that we've seen, especially highlighted through the pandemic, and being able to name it and talk about it together, I think has been a huge force as far as our resiliency. It goes back to that progress piece. if we name it and we kind of can navigate it together, that feels better than kind of carrying that alone. And I want to say too, for our people who are people of color that we work with, or people of color that we treat, it's really important to name it so that our colleagues and our patients understand that we understand what's going on.
So we want to do another break for 2, maybe 3 minutes, and I want you guys to put your heads together at your tables. And with all this talk of systems and what we can do within our systems to help prevent moral injury, talk about what you think that would look like in your system, in your workplace. And we'll pick on a few of you afterwards to hear some of your ideas. All right, let's reconvene. Now, I'm not going to be as nice as Maureen and let you guys get away with being too quiet here. So I'm just going to pick on the couple tables in front of me and.
That's because you're the doctor. But I'm bummed.
Good at picking on people. What did you gentlemen discuss?
Mostly we talked about employee assistance programs that don't work.
Well, and the other part of it, the biggest part of it for me is, and I talked about it with them, is taking the stigma away with it. Because we've got such a stigma attached to it, especially in our profession, because we're superheroes, right? We can't admit we have flaws or we're having problems. And leaders have to be willing to step up and say, look, this is going to happen to you over a long career. And you have to know what resources are available to you and how to take care of these problems so that we get worse.
So did you guys all hear that? I think the main point was there's a stigma about being morally injured or burnt out because we're expected to be superheroes and just bear all this stuff on our backs for society. What would solutions for that look like, I wonder? I mean, the first thing that popped into my head is it sure helps to have people who've been there on the ground doing the frontline work then become the administrators and the managers. So, or like myself and Maureen, be doing both at the same time. So we have like our finger on the pulse of what's happening.
I think, like we talked, it's easy to see it because I've seen it. But forcing somebody to go and get the help you know they need is not going to fix it, because if you force somebody to do something they don't want to do, it's not going to help the situation. It's just probably going to just make them more irritated and more vulnerable, I guess. So you got to want to help yourself.
Sure. And I think that happens because we carry around, the stigma isn't just something that's done to someone. Stigma is all around us and it seeps into us. And so we carry around those stigmas about, what it's like, what it means to have a problem with your mental health or to be depressed or, to be tough or whatever it might be.
I think when we're talking about that, one thing that comes to mind is when we were talking about culture earlier in the first presentation. We talked about that there's a lot of discussion of resiliency, right? But that the people that we hold up as being the best of the best are people that are working 60-hour weeks, are people that are bending their boundaries, and people that are being superheroes. And so I think it's, all right, what am I doing as a leader to model taking care of myself? And what are we doing, not just within my team, what are we doing as a culture to model that? Because if they don't see leaders doing it and all our workers are seeing this is what it looks like, this is the epitome of the profession, sacrificing all, being all, not letting things fall through the cracks, then that's what they're going to think success looks like. So what are we doing to take care of ourselves as leaders?
I think the one thing that I've always kind of looked at, it almost has to be bred out of the job, because the older you are, you've already set your ways, old dog, new tricks, just like your example of, coming in as a new nurse with, hey, this is not right policy. Eventually it probably got bred out of the older nurses. I think that's the only way it's gonna, I guess, affect the system is obviously we have education now that we're talking about it, we're addressing it. It's not, the stigma and the culture is not gonna go away until the old dog decides to step down. And no offense to them, it's just how it was, but now we're in a different culture, we're a different lifestyle, our generations have changed, and the way they deal with their emotions has changed.
The stigma around any emotional problem is huge. I mean, if you break your arm, it's obvious to you that you have to go to the doctor and get it fixed, but you know, most employees think, well, this will go away, I'll just ignore it, or I'm not telling anybody, then they're gonna look at me different.
They also might not know what it is or might not have the right words for it.
Good point.
Because there might be, someone might have trouble going for help for hopelessness or depression or anxiety, but if they have this concept of, wow, I think I'm just suffering from moral injury. You know, this is a concept that was originally in like military literature. And so maybe if you sort of reframe it in a way that, it doesn't mean you're weak to be morally injured. It happens to, you know, it's happened to warriors since the beginning of time that have had to, you know.
And it means you have integrity, right?
Yeah,
People
right.
can only get morally injured if they have morals and
So
values.
what we're hoping is that giving new words for it, giving a new framing of what's happening gets away from some of those old stigmas.
So Maureen, the one comment that you said, you know, because we're all doers here, we don't like failure, so we're gonna work 60 hours. We're the problem. We do not provide the opportunity for others to step up. And sometimes you gotta let things wobble, hopefully not abject failure, but fail a little bit to provide that opportunity for other folks to say, hey, maybe I can help here. Instead of, hey, Maureen's gonna take care of it, or, you know, Neil's here, we're good. So I think we need to look at us as, quote, superheroes, and maybe we just need to take all that garb off and be regular folk, right? So.
No, I love that saying, like allowing the system to fail. That's my mentor's favorite saying. So.
I'm going to pick on this table over here. Where are you guys from? What organization?
We're all from Asheville, well, because of this gentleman, the rest of us are from Asheville County.
And what is your profession, your field?
We're public health professionals of various sorts.
I'm curious to see what kind of ideas this sparks for you guys.
The biggest thing we saw was that frequently there's a disconnect between the leadership and those of us who are doing the grunt work, especially for public health. The Board of Health is frequently people who never step foot inside the health department other than for their meetings once a month. And that's usually after hours, you know? So they don't see it other than to critique it from, hey, one of my constituents called and said that you cited their hotel for dumping sewage on the front lawn. Yeah, that'll happen, you know? So that disconnect, you know, not having a way to even show our leaders what it is we're going through on a day-to-day basis, and them not necessarily even having an interest. Even from the state level, occasionally decisions are made that everyone in the state has to use this system, but not everyone in the state had input into that system. In fact, nobody was even asked. These are things that we just have to deal with. They're externalities that we don't get to use our judgment on. We just have to deal.
Yeah, that's a big take-home point, I think, from what we're saying is that you need, you know, some fields would call it sort of stakeholder input. We have some more slides that we won't really have time to get into, but, you know, one of these ideas is, you know, we all have these metrics that we use to measure the work that we do by. And, you know, metrics are great from a certain standpoint because it's sort of like that, kind of like that saying, well, if you didn't measure it, you know, it didn't happen or something like that. But the problem is the things that you're not measuring start to get ignored. And so by sort of putting a magnifying glass on certain aspects of what we do, what are we not what are we not putting that magnifying glass on? What are we not looking at? And oftentimes it's things that are hard to measure. It's things like collegiality, it's things like communication, it's things like mentorship.
I always say for the population that we treat, they don't die 25 years earlier than the general population because of something we're doing wrong, right? They're outside of our normal healthcare systems, and a lot of what we can do in those situations, because they're often so ill with schizophrenia or bipolar disorder or whatever they're dealing with, is to bring dignity to that situation. Try measuring dignity. Like it's impossible, but it's a huge
Or
part
is
of what
it,
we do.
right?
Or is it?
Maybe it's not. And so the question is, who's coming up with these metrics? And are they including the people that are on the front lines actually doing the work? Because the other byproduct of having metrics is you have people eventually learn how to work their way around them, or cherry pick, or make their own numbers look good. And if you're not getting regular input from the people doing the work, you might lose sight of what kind of cherry picking is happening and what sort of harms are happening because of the metric you created. There's this example that's kind of famous. It was New York State. They developed metrics for cardiologists who were doing coronary catheterizations, and they wanted to look at like the survival rates and the rehospitalization rates after those procedures. And so it sounds great, right? We all want to have a system that promotes safe coronary procedures, right? That's what we want. It sounds good on the surface, but what happened is doctors in that state started to refuse to operate on people who had any kind of pre-existing medical problems, because those are the people that were going to have fatalities returned to the hospital. And so in an attempt to make their numbers look good, it actually killed people. And unless you have input from the people that are on the ground that are paying attention to what's happening, you'll lose sight of what's really important. And I think another road to moral injury, I think, is when we start to feel like our managers don't understand why we got into the fields we got into. And sometimes the measurements and the metrics that we have to meet give us the feeling that they don't really understand why we're doing this. They're not measuring the right stuff.
I have a positive on the metrics. When you do start listening to the right stuff, when I was a new nurse, they were looking at how do you call a code, but not, so it's like a pre-code blue is basically what it was, and I forget what they called it. But it was for when a nurse, all the vital signs were good, everything looked okay, but the nurse had an intuitive feeling that things were trending down. And so they could call this code, and it would bring people from different parts of so off of their unit. So the code responders would be from off of their unit, and they would evaluate the patient. And they decreased their code blue numbers by some like astronomical amount just by doing that, right? So nurse intuition, to your point, is very hard to measure, but they figured out a way to do that through this really creative plan. So I think it is about being creative and what do we want to, what's our goal and how can we incentivize reaching that goal.
So speaking of superheroes, I feel like that's the Spidey Sense code. I want to pick on one more table. How about this big table over here? Where is this group from? We'll get you a microphone.
I think all right, well, so one of the things we talked about is like the moral responsibility to the patient. So a couple of us are paramedics here, so kind of doing things where you're doing something that's best for the patient, even though despite that already know the outcome. So I don't know, resuscitating somebody who probably has a slim chance of survival, but you're doing it anyway just because you feel like that's in the best interest for the patient and for the bystanders, family members, loved ones that are watching.
that's a powerful one.
Yeah. So like, it's like you said, it's almost like demoralizing to even despite to do that every day, you know, and then like our health care system is kind of stressed. So after you do that, you go and maybe you take a different call for something that, you know, isn't exactly what you would deem like more like a medical necessity. So you go from like a critical incident to like a, you know, something that is
Taxi call.
I hate to use the word taxi call, but yeah, you feel like it's a taxi
We
call.
all know what you mean.
But like, you know, just something that's like, you think like, you should have called like maybe an urgent care, maybe like found a way to the hospital, call your primary care, stuff like that. So I think a lot of our healthcare system, especially in Northeast Ohio, is definitely struggling with dealing with that kind of stuff. So
Yeah, and I hear all kinds of, well, personal and individual sort of challenges there, but also systemic challenges. Even just down to sort of, if you have a critical call where, you know, where someone's has died and there's family there and it's a, you know, emotionally charged situation, is there structure in place to debrief from that, to take a break? You know, is there an extra sort of break or huddle or something that's needed when something like that happens? And then in terms of, yeah, the system kind of using resources inappropriately, I think, is the other category that seemed like you were mentioning. How do we create a system that incentivizes people to use the resources correctly and to use the right level of resource that they need? I don't think it's impossible. And I think it's worth looking at, because not only does it save money, and there's always like an economic argument for that sort of thing, but it helps with our spirits and helps us feel like what we're doing is important.
I think because when we start to kind of think about all of these different problems, I think it's really important to take a step back and think about the solution. Oh, not closer to you, that is not the solution. But thinking about what can I do? Where can I elevate my voice? How can we collectively kind of push the system to grow? I do think that is, to kind of wrap up here a little bit, the pandemic has been awful. I think probably this post-acute phase has been some of the hardest, especially as we're dealing with staffing. But I do think that there is opportunity here, right? So people, like I said, everybody kind of sees the holes in our healthcare system now that they're real and people are having to deal with the consequences on a more regular basis. So what can we do to operationalize that opportunity? It's not easy, and sometimes it does mean work outside of work. Sometimes it does mean political work or contacting representatives, all of those kinds of things. And I know that sounds arduous and it sounds like it doesn't work, but I promise you it does over time. We've seen changes in laws over time. The big one that I want to do is the Medicaid reimbursement for nursing services. I don't know who in here that's impacted, but that would be my next big goal, is to change reimbursement rates so that we're incentivizing the right things. So I don't want to get lost in the sauce, because you're right, all of these problems are huge and big and they're terrible, but we have the power to change them if we take those steps. Bless you.
An enormous financial argument for prevention of burnout and moral injury. You know, I don't know the numbers for all the different kinds of professions in here, but they say that if a doctor, you know, if you lose a doctor off your staff, you know, if they just throw their hands up and quit because they're fed up with it, just the process of replacing that doctor costs about 2 to 3 times that doctor's salary. And that's with the productivity loss, it's with the price of recruitment, it's with the time it takes to bring them up to speed, and it's also in the patient safety problems that happen as they're becoming burnt out, and their burnout spreads to the rest of the team that they're working with. And so talking to big systems, I think I just want to foster more opportunities for these conversations to happen, because I think we can figure out how to speak each other's language. And there's a way for us all to communicate about this and make change.
Yeah, the last thing I'll say too, and I know we're over time, but the last thing I'll say is one of the best things that has happened in the past year is us sitting down with one of the local hospital systems that we were struggling with the most as far as we pink slipped them. They'd get there, they'd get discharged. And it took like the world to pink slip them, like it was harrowing event. But we sat down and we talked as colleagues and we developed systems to communicate better. And nobody was trying to do the wrong thing there. Everybody was trying to do the right thing through their own lens. So just can't harp on it enough. Relationship is hugely important. Thank you so much, everybody.